All right, so I'll begin just for the interest of time. Again, I'm Dr. Dwayne Brown. I am the medical director of the Comprehensive Headache Center at Capitol Health Neuroscience. And today I'll be talking about a very important topic. So the objectives of my talk today, first, I'm going to review some of the most common headache disorders. Then we're going to look at the pathophysiology. So basically what causes these disorders to happen. And then finally, we're going to review the diagnosis. So when we see these patients, how do we come up with making the appropriate diagnosis and then how to treat these headache disorders? So there are several different headache conditions out there, and they're all divided into two groups. So they're either primary headache disorders or secondary headache disorders. Secondary headache disorders are usually headaches that's caused by another etiology. So there's an underlying condition causing these headaches. So having high blood pressure can cause a headache to happen, or having jaw pain or lack of sleep can trigger a headache to happen. And then there are those primary headache conditions that are due to the headache itself and not due to another condition. The three that I'll be talking about today includes tension headaches, migraine headaches, and cluster headaches. So the first one we will talk about is migraine headache. Now, unless you know someone who suffers from migraine, many of us do not realize the significant impact that migraine can have on individuals. It is a very disabling headache condition, and those individuals who suffer from migraine are oftentimes not able to work or attend school or even engage in recreational activities that they enjoy. So just to put things in perspective, migraine is the sixth most disabling disease in the world. And every year, it actually has significant impact on the US economy. So around 36 billion is lost per year in terms of healthcare costs and loss of productivity. In fact, around 1 billion is spent every year just getting brain scans to rule out another pathology that could be causing the headache. And due to the disabling condition, around 9 out of 10 people cannot work because of their migraine. So around 157 million work days are lost due to the impact that migraine has on individuals. So what causes the migraine? There's several different theories that has been thrown out there. So the first theory was that migraine was due to vasodilation of blood vessels, but we've learned that that's not quite the truth. What we do understand is that certain individuals are more predisposed to having migraine. So that is, they're born with certain genes that makes them more vulnerable to getting migraine attack, essentially. And once these individuals are exposed to certain environmental triggers, then that will actually bring out the actual headache condition itself. So there are different phases of migraine. There's 4 phases to be exact. So there's a prodromal phase, the aura phase, the headache phase, and then the postdromal phase. And I'll cover all 4 phases in subsequent slides. But as you can see here, there's this vulnerability stage, which those patients who are predisposed to migraine will experience. And then once they're introduced to certain triggers, so whether that's lack of sleep or certain environmental triggers, then that will now initiate the actual cycle to begin. So the first stage of migraine rather is the prodromal phase. So this is where the individual, a day or 2 before the migraine starts, may start to experience certain symptoms. So quite often in my clinic, patients will tell me, well, 2 days before my migraine starts, I start feeling just really cranky, or I may just feel extremely exhausted, or they may have neck pain. So this is a prodromal phase. And what's happening at this phase is that the hypothalamus, that's pictured right here, so this is a part of the brain, once that's activated, it triggers the release of certain peptides that are implicated in this pathway. So once these peptides are released, then it causes a lot of these symptoms that I previously mentioned. So then the other phase is the aura phase, and around 25% of patients will experience this phase during a migraine. And so this is usually a warning sign that a headache is going to happen. And this is manifested in several different ways. Mostly it's visual disturbances, where the person may complain of seeing flashing lights, dark spots, they may lose peripheral vision, etc. In others, it could be sensory. So they may have numbness on one side of the face or the arm. There could also be motor involvement, where they become weak on one side, almost looking like a stroke. And then finally, some people will have speech impediment. So you can see that a lot of this is somewhat similar to having a stroke. Now, the implication of having migraine with aura is that it does increase one's risk of having a stroke, but a very low risk nonetheless. So we tell our patients with migraine with aura to control their vascular risk factors. So you want to work on your blood pressure. If you have high cholesterol, you want to control that. If you're diabetic, you also want to work on that. But the one thing you do not want to do is to smoke. Smoking actually increases one's risk 7 times of having a stroke if they have migraine with aura. And then in our young females of reproductive age, if they're on birth control, we tell them to avoid estrogen-containing birth controls or be on a birth control that has no estrogen at all. Just because all those things that I mentioned before further predisposes them to having a stroke if they have migraine with aura. Now, the exact pathology behind having an aura, it's a detailed one, but just to simplify it, basically, certain neurons are excited in the occipital cortex. And when this happens, it basically causes this spreading depolarization, where there is activation of neighboring neurons traveling at a very fast speed of 2 millimeters per minute. So once that neuron is activated, it basically causes all the neurons or all the nearby neurons to be activated. So this is what causes the aura phase. Then the other phase is a headache phase, and that's the phase that the person experiences. So there's certain criteria that goes into diagnosing someone with migraine. So typically, to make this diagnosis, the headache has to last between 4 hours to 72 hours if untreated. So if someone comes to me and they tell me, well, I have a headache and it lasts for 10 minutes and it goes away by itself, that's likely not a migraine. Migraines are usually unilateral. The description of the headache is usually pulsating or throbbing. There's usually light sensitivity or noise sensitivity or nausea. So in fact, to meet the diagnosis of migraine headache, they have to have light and noise sensitivity or nausea. And some people will also complain of osmophobia, which is certain smells will trigger a headache to happen. And then finally, there's a postdromal phase. So oftentimes I see a patient in clinic and they'll tell me, well, the actual headache phase lasts for around 3 hours, but I'm technically out for the entire day. So they'll tell you that they feel drained or confused or washed out for the entire day. That's all part of the migraine. So there's several triggers for migraine, and this list is not quite exhaustive, but I presented some of the most common ones. So hormonal changes can trigger headaches to happen. So you'll see young females telling you that their headaches are worse around their menstrual cycle. This is oftentimes due to the drop in the estrogen levels around this time. Stress is a big factor. So we always tell our patients with migraine to make sure they work on reducing their stress, because that's a big thing that will, no matter if you're on the best medications, if you're not well controlled from an emotional standpoint, that can trigger a headache. Certain foods can also trigger a headache. So in fact, I had one patient 2 weeks ago who by herself eliminated gluten from her diet. And by doing that, she was able to get rid of her headaches. Now, the triggers are not the same for everyone. So we tell patients to keep a diary. So if you keep a diary for your headache, what you may notice is that you may see a certain pattern. So you may notice, well, if you don't sleep 8 hours one day, that may trigger a headache. Certain food, specifically wine, cheeses, that can trigger a headache to happen. Skipping meals also is another big thing. So I always encourage my patients with migraine to eat very frequent meals, but small meals throughout the day. Caffeine, which is another one that a lot of people enjoy. While caffeine can be used to treat headache, if you consume too much, that can actually trigger a headache to happen. So there are modifiable triggers, but there's some things that we can control. So barometric pressure changes is another big one. So some people will tell you that whenever it's going to rain or storm, they know when a headache is going to come on. And that's an actual big thing. Why that happens, we don't know. But again, certain weather changes, especially if it happens precipitously, can trigger a headache to happen. So it's important to recognize certain red flags. So individuals who suffer from migraine, and especially chronic migraineurs, sometimes it's hard to predict when something more serious could be happening. So I tell everyone who suffer from headache to pay attention to these red flags. And what this means is if this were to happen in someone who suffers from a headache, or even if it's a new onset symptom, this oftentimes suggests that something more serious could be happening. So if you are used to having headaches, let's say 4 times a month, and then you experience a new kind of headache that seems very different, if it's the worst headache you've ever experienced, or a headache that just makes you not able to do anything, that's usually a red flag. That may suggest that you should seek immediate medical attention. If you have a headache with fever, or if there's neck stiffness, or especially if there's a seizure or double vision, definitely also seek immediate medical attention. This could possibly be a bleed or a stroke or even a tumor that's growing. Another important one for us is headache after a head injury. And this applies to anyone essentially, but oftentimes I'll see an elderly patient who lives alone who tells me, well, you know what, I fell last week, hit my head, never sought medical attention. This is a very scary thing. If you fall and you hit your head, you could possibly have a bleed. And if that expands, that can actually lead to death. So I tell anyone, if you've had any kind of injury to your head, especially if there is neurological involvement where the person just seems to be acting very differently, take them to the ER, get immediate imaging just to rule out a possible bleed. And then just for the interest of time, I'll cover the last bullet point, which is new onset headache over the age of 50. So if a person's never struggled with headache, and then all of a sudden have this new onset headache after 50, this is a red flag. One of the conditions that we're concerned about is something called giant cell arteritis. So sometimes you can have inflammation in the temporal artery that can actually trigger a headache. Why this is important: if left untreated, the person can actually go blind from this. So it's important to diagnose this pretty much at the very onset. Some things that kind of lead to this condition is if the person complains of pain on palpation of the temporal region. So in this region, especially if there's visual impairment, that's a big red flag. Basically the treatment for this is steroids, but it needs to happen immediately. So there's several different treatments for migraine headaches, and how we decide how to treat patients depends on how frequently they're getting their headaches. So the American Headache Society recommends that if you're getting more than 4 really bad headaches per month, you should be on a daily migraine preventative. Now, if you're getting less than 4 headaches per month, we could just use something for rescue. So something to take to get rid of the headache immediately. So basically examples of abortive treatments that we have available includes NSAIDs. So a lot of people will just take an ibuprofen or naproxen over the counter whenever they get a headache. And while that's okay, if used too frequently, so I tell patients to avoid using it more than 10 days per month, it can actually cause the opposite. So you can get rebound headaches from taking too much NSAIDs. Triptans is probably the most common migraine abortive regimen that I use. So in this class, there's a lot of different drugs in this class. So there's like sumatriptan or Imitrex. Another one is rizatriptan or Maxalt. Then there's longer acting triptan called Neurosciences. These basically act on the serotonin receptors that are implicated in the migraine pathway, thereby just blocking the whole headache pathway. Certain antiemetics, so medication that we use for nausea, does help in headaches. So an example would be Reglan. The other name for that is metoclopramide or Zofran. Now, in 2018, we had these new classes of medications that came out called the CGRP, which is calcitonin gene-related peptides. I'm actually very excited about this class. It's a wonderful class in terms of side effect profile. A lot of patients love taking this medications from this class because they're very well tolerated. In this class, we have Nurtec or Ubrelvy. You've probably seen commercials with Khloe Kardashian and I think Serena Williams. A lot of people are on this class, and it works incredibly well for patients with headaches. We have another new class that came out, again, 2018, 2019, called, basically this drug works on the serotonin 1F receptor. It's called Reval. The other name for that is lasmiditan. And this is a very important drug because unlike a lot of medications that we use for migraine prevention, if a person has a history of strokes or heart attack, certain medications can't be given, especially the triptans. So this medication itself is safe for patients with cardiovascular risk factors. Then we have the ergots. So this includes like dihydroergotamine. That's another good regimen for migraine rescue. The problem here is if the person suffers from stroke or heart attack, it is completely contraindicated. And then there are people who do not like to take medications. So I come across patients all the time. They're like, Dr. Brown, I know I have these headaches, but I don't want to take anything for them. There are non-medication approaches. So there are certain devices, specifically the cephalid device. So this is a device that you can wear on your head that basically stimulates the trigeminal nerve endings that are involved in headache and trying to stop the cycle from happening. And then there's certain interventions that I could do in the clinic. So some people come in for nerve blocks where I will inject them with local anesthetic, lidocaine or bupivacaine, just to give them some relief. Now, how long this lasts for depends on the patient. For some people, it could be 2 weeks. Other people, it could be a longer effect. And now, if someone comes to me and they're getting more than 4 headaches per month, then we should entertain starting a preventive regimen. Now, most of the preventive regimen that we give for migraine, they belong to other classes. So some blood pressure meds, specifically the beta blockers and calcium channel blockers, help to treat migraine. Some antidepressants, specifically the tricyclic antidepressants, those also help to treat migraine. And then there's certain anti-seizure medications. So in this class, I like Topomex. It's a wonderful medication. There's gabapentin or Depakote. And again, we have the CGRP class. So this is one of my favorite classes of medication because of the side effect profile. In this class, we have some once-a-month injectables. So for people who do not want to take a daily medication, this is a wonderful class. They'll do an injection once a month. The drug actually stays in their system for at least 30 days, which is why they only do it once a month. And that actually helps with the headache. Exciting, Botox that people use for cosmetic purposes actually has been proven to be effective for patients with migraine. So at Capitol on Fridays are my Botox days. Patients will come in and I'll inject them in 31 areas across the scalp and in the neck. And this actually lasts for 3 months. So every 3 months they come back in for Botox. And I've seen people gone from daily headaches to really 1 a week or none at all on this regimen. And again, if I see someone in clinic and they don't want to do medications, they want a more natural approach, there's certain lifestyle changes that a person can do. So exercising regularly has been proven to help in migraine. Cognitive behavioral therapy, where a person will meet with a therapist and basically work on like stress management, et cetera, has been proven to be effective. Biofeedback, et cetera. There's also certain natural supplements like magnesium, riboflavin, which is vitamin B2, and coenzyme Q10 that a person can take daily that actually helps with headaches too. So the next headache condition I'll talk about is tension headaches. Now, this is the most common headache condition, and I apologize for the spelling. I just realized the A is missing. But this is the most common headache condition. Most people do not present to clinic for this condition though, because they're not as disabling as migraine. And most people take an NSAID and that will help with the headache. The exact cause of this is not quite understood, but some of the symptoms that suggest tension headache versus migraine headache includes the fact that it's not as debilitating. It's usually dull. And unlike migraine that is unilateral, tension headache, the person will complain of just this band-like pain across the head. And oftentimes there's neck and shoulder, just tightness or involvement. One thing to point out here is that stress is the most common trigger for tension headache. So it's very important to try to reduce your stress as much as possible to mitigate the effects that you get from tension headache. Other triggers that's similar for migraine can cause tension headache to happen. So again, you want to work on getting at least 8 hours of sleep. You want to stay hydrated, etc. So unlike migraine headaches, where we said the duration was 4 hours to 72 hours, tension headache can last longer. So can range anywhere from 30 minutes to 7 days. Again, some differences is that unlike migraine that is typically unilateral, tension headaches are bilateral. They're again mild or moderate in intensity, and they should not be aggravated by physical activity. So most people with migraine will tell you that when they get a headache, they have to go lay down. In tension headache, that doesn't typically affect them. And there should not be more than one of the following. So either they have light sensitivity or noise sensitivity, but never both. If both are present, then likely it is migraine headache. And nausea, a person suffering from tension headache usually does not complain of nausea. So workup for tension headache, and this is very similar to migraine, is if a person presents to you, especially for the first time, it's probably worthwhile getting some form of brain imaging to rule out a secondary cause of the headache. So this can either be a CAT scan or an MRI of the brain. Treatments for tension headache, again, rescue NSAIDs. So an ibuprofen over the counter, naproxen helps. Triptans, a lot of people don't realize, can actually help in tension headaches. And then narcotics. So narcotics is not one that I tend to push for just because they have addictive qualities. And there's a lot of different medications that can be used that are more effective and does not have the addictive component to it. For prevention, I won't go into much details, but again, in this class, the tricyclic antidepressants, so specifically amitriptyline or nortriptyline, can be very effective. And then the anticonvulsants. So gabapentin is one of my favorites for patients with tension headaches, but Topamax can also work, or Depakote. In this group, because we mentioned that stress is a big component, a lot of the lifestyle or behavioral modifications are very effective for this condition. So biofeedback or cognitive behavioral therapy or just relaxation techniques can be very effective to reduce tension headaches. And then the final headache condition we'll talk about is cluster headache. So this is perhaps one of the most debilitating conditions anyone could ever experience. Is oftentimes referred to as a suicidal headache. It belongs to a group of headache conditions called the trigeminal autonomic cephalgias. So in this group, there are one-sided headaches where the person will either have some autonomic features, so they will complain of either tearing of the eyes or runny nose, or one eye that actually looks smaller than the other. So the eye actually would droop. For cluster headache, there's a big male predominance. So for every 4 males, you'll probably have one female with cluster headache. And it tends to be more common in African Americans when compared to their Caucasian counterparts. Now, the average age of onset is between 20 to 40 years, and they tend to happen in bouts. So someone suffering from cluster headache will tell you that, hey, I have my headache around the same time of the year, typically around December or early summer, so around July. And it tends to happen around the same time of the day. So either early morning, and that's the time it mostly happens, around 1 to 2 a.m., waking patients out of sleep. But it can happen at other times. So it can happen at 3 p.m., etc. To meet the criteria for cluster headache, the person has to have at least 5 attacks fulfilling the following criteria. So the duration of the headache, it should be no more than 3 hours. So the time frame is between 15 to 180 minutes. And someone suffering from cluster headache can experience the same headache up to 8 times in a day. Now, the person should have either one of the following things that I will list below. So there should be either conjunctival injection, so redness in the eye or tearing. They'll sometimes complain of just runny nose, or one eye that looks swollen, or one pupil that actually looks smaller than the other one. And then they're oftentimes very restless and very agitated. And like I mentioned before, the headache can happen up to 8 times in that day. Now, this is depicting when, even though cluster headache can pretty much happen at any point, January and February tends to be the time when it's more common, as well as July and August. Why this happens, we don't know. The idea is that it tends to happen around the shortest and the longest days of the year. Now, again, this is showing the circadian periodicity to cluster headache. So typically they happen around the same time. Most times patients suffering from cluster headache will tell you that they were sleeping and woke up around 1 or 2 a.m. with a really bad headache. But again, it can happen at other times. Now, there was a study done looking at some of the most painful conditions in the world. And this included childbirth, kidney stones, gunshot wounds, shingles. If you've ever experienced any of these conditions, you can attest that these are a very painful condition. Surprisingly, or not surprisingly for some people, cluster headache was the #1 most painful condition. So every time I've seen a patient in my clinic for cluster headache, I've seen people just want to commit suicide because of how bad it is. Now, so because of how disabling it is, it's important to make this diagnosis. Oftentimes, patients are given the wrong diagnosis. They're treated as a possible migraine headache or tension headache. They're not getting better. They're suffering from really bad headaches, and they're wondering, why is it that nothing works? So it's important to make sure that we're diagnosing patients correctly, so that way we can treat them with the right regimen. When someone is going through their cluster cycle, there's certain things that you want to avoid. So someone suffering from cluster should definitely avoid drinking. Alcohol is not a thing that you want to consume around the time that you're having your cluster cycle. If you're taking certain medications, specifically nitroglycerin-containing components, you want to avoid doing that because that's definitely going to trigger or make your headaches worse. I always encourage my patients with cluster headache to avoid flying or climbing mountains whenever they're having a cluster cycle, because that will only make things worse. And then for males on male-enhancing medications like Viagra, etc., you may want to avoid using those around a cluster cycle. So briefly, I'm just going to talk about the most common rescue regimen for cluster headache. So if you're going to do a treatment and you need to do a triptan, you want to use only the intranasal form or the IV form. The pill form will not be effective because it will take too long to kick in. So that's where a lot of primary care doctor providers will make a mistake, because they'll start a patient on sumatriptan tablet and it doesn't work, because cluster headache, it comes on very rapidly. So you want to give them something that's going to kick in immediately. Sumatriptan 6 milligrams subcutaneous is a great treatment. And oxygen is another good treatment to give the patient. Oftentimes I'll prescribe both, and I'll explain that in subsequent slides. So for oxygen, this is a good one that I give patients, because for the triptans, the insurance companies will only give around 9 injections or a spray per month. And if the person has more than several cycles for that month, they're going to run out of their medication. So prescribing oxygen for them, it needs to be 100% non-rebreather oxygen. And when they use this, they have to use it for around 20 minutes. That is a gold treatment for a lot of patients. After using it for 15 minutes, they'll tell you that the headaches will go away. The limitation here is that obviously using oxygen, there's a tank. So it's not always feasible for someone to travel with the oxygen tank. So just taking the injection or the spray is oftentimes more feasible. So what I do, I recommend my patients to keep the oxygen at home, and if they have a cluster cycle at home, to use that instead. But if they're at work, etc., take the spray or the injectable form to use them. Another thing when it comes to cluster headache is it's important to start a transitional therapy along with a maintenance therapy while they're having their cluster cycle. So the reason why the transitional therapy is important is the maintenance medication to the right, they will take a while to kick in. So if you're going to start verapamil, which is the gold standard for cluster headache, it could take up to a month or even 6 weeks for it to kick in. So oftentimes I'll prescribe a steroid taper, so prednisone, and you're doing that so that will help to control the symptoms until the maintenance therapy kicks in. For the interest of time, I'm not going to go in details with the rest of the treatment here. But as you can see, if the person has any contraindications to verapamil, whether let's say their blood pressure is super low, or they have certain cardiac abnormalities that excludes them from using verapamil, Topamax is a great option, or even Depakote. For transitional therapy, sometimes patients will come into my clinic and we'll do some occipital nerve blocks as transitional therapy until the maintenance therapy kicks in. So finally, to summarize what we talked about, there are several different headache conditions, and it's important to take a really good diagnosis, or as a patient, it's important to make sure you're giving your doctor all the symptoms, everything that potentially happens when you get a headache, so that your physician can make a correct diagnosis. Because again, that is going to be very key. If we're not getting enough information, we're probably going to give the wrong diagnosis and you're not going to get better. So it's important to just be as detailed as possible when you see your PCP or your neurologist. And then finally, there's several treatment options for these conditions. How I prescribe my medications, I take into consideration the patient's side effect profile. So again, let's say a patient is seeing me and they have migraine headaches, but they also have seizures, then maybe picking one from the anti-seizure class may be the best way to go. Or if they have migraine, but they're also depressed at the same time, picking one from that class may be the way to go. And that's it for my slide. If there are any questions, I'll be happy to answer them at this time.
Thank you very much, Dr. Brown. Did a wonderful job. And yes, we will be taking questions now. You can put them in the chat box. Also, if you can complete the evaluation survey, and if you're interested in the recording, I have the link for that as well. And I will stay here for like an extra 5 or 10 minutes so people can complete the evaluation. Like I said, we really appreciate that. We want to know what you thought of the program, and also I get suggestions for future programs. So, so please fill that out. And do you want to read off questions, Doctor? Let's see.
Yeah, it looks like Ronald just posted something. Where do you feel head? I'm sorry. Where do you feel in head a stroke headache? I'm assuming you're asking where, if somebody has a headache due to a stroke, where do they feel the headache? If that's where you're asking, essentially it can happen anywhere. A lot of conditions, so whether that's a stroke or a bleed that triggers a headache, you basically treat the phenotype of the headache. So if it presents like a migraine, you basically treat it with migraine-specific medication, etc. What about aspirin for headache? Again, the treatment is geared towards what phenotype the patient is telling you. So if there's more, and it also depends on how frequently they're getting them. So if somebody is getting headaches after stroke and they're getting around, let's say, 8 or more headaches per month, typically I would suggest starting a preventive medication along with a rescue regimen. Aspirin, obviously, after a stroke, that's something that we recommend taking, especially if it's an ischemic stroke, just to prevent you from having further events, essentially. So it's either aspirin 8 to 1 milligrams. Oftentimes, your neurologist will put you on cholesterol medications too. As someone who gets migraine triggered by the sun, is this something that might be in your genes, like you mentioned prior? So certain genes will predispose you to having migraine, and as a part of getting migraine, there is that photophobia. So what you do for that, there's no medications out there for photophobia. What we recommend is sunglasses, so just having one on you at all times. And for those people who, let's say, use a computer a lot and just have to look at screens for an extended period of time, a lot of people have been finding good success using like a blue light filter, or just putting this like blue light screen over the actual computer. That will oftentimes help people to avoid the excess light that comes in. Let's see. For tension or migraine, is food often the most common trigger? I have been cutting various foods, ingredients out, but it's hard to zero in. So great question. The trigger varies from person to person. For some people, it is food, and the food actually differs among people. So what I recommend, again, is just paying attention to when you get a headache. So just keep that diary. So you may notice every time you consume a certain type of food that causes a headache. And if that happens, then you can eliminate that from your diet to see if that keeps it away. But in terms of what's the most common trigger, perhaps stress is the one that's oftentimes encountered. But I mean, it could just be lack of sleep. So getting 8 hours, it could be as simple as being dehydrated or just not eating a lot. So the triggers vary. Do you treat patients that are 17 years old, and are migraine meds you mentioned appropriate for a patient this age? So I'm an adult neurologist, and so I technically do not see patients under 18. There are times when I make that exception. So if the person's going to turn 18, then fine. And the reason why I do this, a lot of the medications that I typically give are not indicated for patients under the age of 18. So I recommend patients under the age of 18 who suffer from migraine or other headache conditions to see their general pediatrician. That's oftentimes a place to start. If you're within, the capital regions, close to where our hospital is, a lot of people end up going to CHOP. But again, a lot of the medications we use can be used in your pediatric population. So Topamax, I've seen a lot of pediatric patients on that one, or certain antidepressants. I just know a lot of the meds have to be dosed appropriately, and that's not something that I technically do. So I'd recommend seeing a general pediatrician or going to CHOP, and then once you turn 18, then I'll see you in my clinic. Thank you so much. Are you able to drink alcohol while taking the preventive meds? Great question. I get this a lot. So it's not like you can't drink alcohol, but I do not advise, I advise against it rather. Why? Because alcohol can affect the metabolism of a lot of medications. And if you want your medication to work, then I would avoid anything that could potentially interfere with the amount that you get in your system. The other thing is, if your headaches are triggered by just drinking, then that's going to make it worse. But I've had people who message me, tell me, well, Dr. Brown, I'm going on vacation. Can I drink? And I tell people to do that very sparingly. Yeah. And try not to drink around the time that you're going to take your medications. Are long-term symptoms of head trauma concussion worsened by amphetamine use prescribed for ADHD? And is cognitive decline a symptom of either or persistent headaches? So this is a loaded question and a very good one. So I do not know of any long-term effects of using an amphetamine while having trauma, after trauma. In fact, I know it's oftentimes prescribed because after concussion, there's several neurological symptoms that can happen. A person may have, may lose attention, they may be dizzy. So I've definitely seen amphetamines being used, but in terms of any long-term symptoms, I'm not aware of any. And then the other part of the question, and cognitive decline is not a symptom of persistent headaches, no. And then Joe, there's someone, is there a specific question that you had about cluster headache?
If you want to unmute, Joe, you could do that, or if you want to write the question in the chat box, that's fine.
Oh, sorry. Yes, that would be much easier this way. So I've suffered from cluster headaches now for about 25 years, seasonally, most often in August timeframe, and in the January-February timeframe. And I've taken everything from Ergomar to Imitrex, what have you. It seems like prednisone really works the best, but I was wondering if anything has advanced, because I really don't like staying on prednisone in such a strong dosage for 6 weeks, twice a year.
So are you on maintenance therapy while throughout the year? So like verapamil or any of the other treatments?
I am not. I'm only treated by my family physician during the actual cluster.
So this is something that you're getting, and especially if it's happening yearly, I would suggest starting a preventive regimen, because the goal of the preventive regimen is to, for lack of better terms, prevent you from getting them on a yearly basis. So the current treatments, they do work. So if there's no contraindications to starting verapamil, that's a good one to start. If you're going to start it, you want to be on at least 240 milligrams, if you can tolerate that. So typically we start around 120, and I typically do that for 1 week and then increase that to 240.
Okay.
So that should be the way to go. There are people looking at, when I was at Yale, someone was looking at psilocybin, which is like this mushroom product that has been proven to be effective. I haven't followed up on where that is, but based on the preliminary data, it was quite effective.
Excellent. Well, thank you for sharing that.
Sure.